Are visible.
Yes, done, sir.
So I am Dr. Abhijeet Khandelwal, Professor, Index Medical College and Hospital, Indore. The topic is today is given is the chronic fibrosing ILD. We all know about the fibrosing ILD. It's a larger group. It's the more than 200 parenchymal disorder, of which the majority are classified as rare. Early and accurate diagnosis can be challenging, and it's difficult to predict the disease progression. And progressive fibrosis of the lung parenchyma is self-sustaining and causes progressive deterioration in lung function, respiratory symptom, and quality of life. Pulmonary fibrosis is sometimes regarded as an indicator of disease progression, and the prognosis associated with the ILD is generally worsening by its presence. ILD with progressive fibrosis may be clinically stable, especially if the disease is mild. In addition, a progressive phenotype can exist in the absence of pulmonary fibrosis. Patient meeting any of the following criteria with 24 months period have experienced disease progression and relative decline in the more than 10% in the FVC, and the decline in the more than 15% of diffusion capacity of lung. For carbon monoxide, uh, or the worsening symptom or worsening radiological appear accompanied with a more than 5%. So if you ask me the risk factor, the generalized risk factor are the UIP pattern of fibrosis, and the extensive traction bronchiectasis on CT, rapid disease progression, no disease regression or stabilization, of with initial therapy, presence of the short telomere syndrome, older age. Other risk factor associated with um, the shorter disease, older age of the diagnosis, shorter disease course, Black American ethnicity. Um, in RA, it means rheumatoid arthritis, smoking status. In RA, the systemic sclerosis, extensive ILD on HRCT. In chronic HP, no identified antigen increasing the age. This is the ILD classification. Uh, it comprised the IIPs, autoimmune ILD, HP, sarcoidosis, and other ILD. In IIP, further classified into the IPF, idiopathic non-specific interstitial pneumonia, respiratory bronchiolitis, ILD, these interstitial pneumonia, cryptogenic organizing pneumonia, acute interstitial pneumonia with autoimmune features like RA, Sjogren syndrome, systemic lupus erythematosus, polymyositis and dermatomyositis, mixed connective tissue disorder, systemic sclerosis, other connective tissue disorder. The other are the idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchyma, fibroelastosis, unclassified IIP. Other the diseases are the lymphangiomyomatosis, Langerhans cell, uh, drug-associated ILD, vasculitis granuloma ILD, other rare ILD. The other ILD they include the autoimmune HP. These are the progressing fibrosing ILD comprised of the HP, non-IPF ILD, and exposure-related sarcoid and other ILDs. Other ILD include the pneumoconiosis, IPF. It includes 20%, chronic HP 20%, CTD-ILD 20%, sarcoidosis 20%. The idiopathic pulmonary fibrosis is comprised of 20% of ILD, and pneumoconiosis. Other ILD, is the slides are visible?
Yes, sir. Yes, sir.
Acha. If that any difficulty, Dr. Chahat, please let me know. Okay.
Sure, sir. Sure.
So it compromise if you go for the review article, a common pathway to organ injury and failure, the fibrosis and the resultant organ failure account for at least 1/3 of the death worldwide. Since fibrosis is common and has adverse effect in all organ, it is an attractive therapeutic target. Contrary to widely held perception, the scar tissue is the available evidence to point on the high plastic nature. These are the other findings which you can the eye, the strabismus, skin scleroderma, keloid, nephrogenic, systemic fibrosis, cardiac fibrosis, diastolic dysfunction, heart failure will reduce or the preserve ejection fraction, arrhythmia, cirrhosis, portal hypertension, ascites, gastroesophageal varices, hepatorenal syndrome, hepatopulmonary syndrome, portopulmonary syndrome, hepatic encephalopathy, hepatocellular cancer. Pancreatic fibrosis, the chronic pain, diabetes mellitus, malabsorption, cancer, renal fibrosis, CKD, hypertension, anemia, electrolyte disturbance, and the pulmonary fibrosis, the restrictive lung disease, pulmonary hypertension, the right-sided heart failure. These are the spectrum of the fibrotic lung disease. Clinical data are the suggestive of biopsy results. The first choice diagnosis and HRCT of the chest, the potential of the disease progression, and the bronchoalveolar lavage, biological feature of autoimmunity, lung function. Presentation and the clinical course of the fibrosing ILD that may present a progressive phenotype other than IPF. The diagnosis of the chronic fibrosing ILD. The ILD include the comprehensive evaluation, clinical assessment include the PFT, HRCT, serology, and sometimes we have to do the BAL. It is a multidisciplinary discussion. The diagnosis of the given entity, working diagnosis of the entity, the provisional unclassified ILD. If require the invasive evaluation, consider BAL or biopsy. Treatment, watch and wait. Biopsy is not always indicated. Disease behavior, monitoring of the disease progression, including the clinical assessment, serial PFT, follow-up HRCT, disease progression, progressing fibrosing ILD. If not, then the no disease progression. The fibrosis management, we have to manage the scleroderma, rheumatoid ILD, sarcoidosis, chronic HP, idiopathic NSIP, unclassified ILD, IPF, antigen eviction. The consider the immunomodulation treatment or observation. Glucocorticoid is the mainstay of the treatment. We have to use the mycophenolate and the tocilizumab and the methotrexate. Sometimes the others, and the other non-pharmacological management is the supplemental oxygen, psychological support, smoking cessation, rehabilitation, symptom palliation, and end of life care. So the monitoring the disease code, disease progression, stable disease, and immunizations. So the fibrosis sign, the commonest sign are the honeycombing and the traction bronchitis, and the mostly the volume loss. Or you have to see the clinically, and if anything worsening, you have to go for the other tests also. So progression signs are the symptoms, lung function, and imaging. These are the signs of the progressing fibrosing ILD. These are the beautiful picture of showing the serial CT imaging of the monitoring the disease progression in the patient with idiopathic pulmonary fibrosis. Axial CT images of the two patients at baseline A and C, and at the 12 month the BND showing the progressive reticulation in both of the lower lobe and progressive traction dilatation of the airway and the reticulation in the both lower lobe. The task with the management of the PF-ILD, we have a lot of the therapeutic agent like pirfenidone, nintedanib, Antacid therapy, phosphodiesterase 5 inhibitor, sildenafil, dual endothelial receptor antagonist. It includes the bosentan and the mesentan, the N-acetylcysteine, azathioprine, corticosteroid, and the N-acetylcysteine, warfarin, imatinib, selective endothelial receptor antagonist like ambrisentan. So if we go for the beautiful flow chart of the management of the pulmonary fibrosis ILD, we have to first make the initial comprehensive evaluation by the history and the physical examination and the symptoms assessment, pulmonary function test, quantification of lung fibrosis on HRCT plus minus biopsy. If there is a mild disease, asymptomatic, FVC decline less than 5% of the predicted at the 12 months or the less than 10% of the lung fibrosis, CT picture are the non-consistent with the UIP, PFT exercise capacity test every 6 to 12 months and the HRCT in every 12 months. Remove offending agent, smoking cessation, close observation, treat underlying cause, immunosuppression for autoimmune disease. But if it is a moderate disease, it means the mild symptom, the patient are not asymptomatic, FVC decline more than 5 to 10% at the 12 month, and the HRCT is the intermediate UIP, and the pulmonary function test exercise capacity every 3 to 6 months, HRCT 6 to 12 months. It needs the multidisciplinary discussion, may require the tissue biopsy, immunosuppressive therapy, consider the initiation of the antifibrotic therapy, pulmonary rehabilitation. In case of the severe disease, symptomatic with decreased quality of life, frequent exacerbation, FVC decline more than 10% or more than 10% lung fibrosis on HRCT, probable of the typical UIP pattern on the HRCT, definite UIP on the histopathology. Again, the pulmonary function test, but here you have to do the CT every 6 to 12 months and the PFT every 3 to 6 months. Again, the multidisciplinary discussion, they consider the anti-fibrotic therapy as a first-line treatment, continuation of the immunosuppression if the evidence of the active inflammation like serology or the inflammatory marker like GGO on the HRCT. Pulmonary rehabilitation, early lungs transplant evaluation, and the palliative care consultation. So now we have the two options in the antifibrotic, the pirfenidone or nintedanib. If we compare the both of the drug, the slower rate of the decline in the FVC 1 year compared with the placebo, reduction in the acute exacerbation, lower the all-cause mortality and at the age of the 1 year. In the cases of the nintedanib, in the pirfenidone, the slower rate in the decline in the forced vital capacity over the 1 year when compared with the placebo, improve progression-free survival, reduction in the respiratory related hospitalization, lower all-cause mortality at 1 year. Potential side effects are the diarrhea, here is the nausea, the weight loss, here is the photosensitivity, elevated liver enzyme in both drugs. Doses, the 1 capsule should be taken twice daily. Here the 3 capsules should be taken the 3 times of that per day. Contraindication, interim, no absolute contraindication, not recommended in the child who class B or the C hepatic impairment. Caution in the patient with the high cardiovascular risk or the high risk of the bleeding. No absolute contraindication with the pirfenidone. Impact on the quality of life, the slower the rate of the decline in the respiratory specific quality of life measured by the St. George Respiratory Questionnaire, and it may slow the progressing of the worsening dyspnea. Again, if we go for the mechanism of action, pirfenidone unknown mechanism, here the tyrosine kinase inhibitor. The adverse effect, as I discussed, the nausea, rashes, abdominal pain, elevated LFT, skin rash, skin photosensitivity is more with the pirfenidone. Here is the elevated liver enzyme, diarrhea, nausea. Metabolism, it is metabolized by the CYP1A2 enzyme. Here is the CYP3A4 enzyme. The primary outcome is the effect of the FVC decline. It reduces the declination of the FVC. It also do the same. If the change in the 6-month walk proctine, reduced declination. Here nintedanib not reported. Dyspnea score, no significant changes. Here is also the no significant changes. All cause of the mortality and the first time of the first exacerbation and the cause is specific mortality, there is a no significant changes. So if you go for the internet safety, in the especially in the systemic sclerosis, the SENSIX trial, patient who has the symptomatic sclerosis and the HRCT scan shows the fibrosis affecting the left, at least 10% of the lungs were included. And the results are the adverse event. The most common adverse event was the diarrhea, which was reported in the 75.7% of the patient in the internal group and the 31.6% in the patient on the placebo group. To conclude, the nintedanib has been the beneficial effect by reducing the rate of the decline in the FVC in the patient with ILD associated with systemic sclerosis over a 1 year of period. So nintedanib in the progressing fibrosis ILD, the phase 3 inbuilt trial, which is showing the 15 countries near about the 153 site. Total patient was 663, 332 in the nintedanib and the 331 in placebo. The primary endpoint, the rate of the decline in the FVC at the 52 week. Secondary endpoints are the at the 52 week, the absolute change from the baseline in the total score on the K-BILD questionnaire, acute exacerbation of the initial lung disease, or death. Death number of the with event and the about the total number percentage. So the inclusion criteria of the possible ILD diagnosis: idiopathic IP, unclassified IP, other IP, HP, rheumatoid arthritis associated ILD, MCTD, mixed connective tissue disorder, the systemic sclerosis associated ILD, other CTD ILD, exposure related to the ILD, and the sarcoidosis, other fibrosing ILD. These are the trial indication list of the possible underlying ILD diagnosis. The characteristic of the overall population, the 2/3 of the patient had the UIP type fibrotic pattern and 1/3 have the other fibrotic pattern. The most frequent diagnosis of ILD was the chronic hypersensitivity pneumonitis, which is near about 26 to 1%. The result in the primary endpoint in the overall population, near about a 76% include the 252 patient in the nintedanib group and the 282, near about the 85% the placebo completed the 52 weeks of the treatment. And the annual rate of the decline in the FVC over the 52 week in the overall population, you can see it is a difference of the 107 ml per year, and the relative reduction was good. The time to first acute exacerbation of death using the data up to the first database log, the overall population and the UIP-like fibrotic pattern on the HRCT, the hazard ratio was 0.68 and the 0.61 respectively. So the results are the secondary endpoints. If we go for that, the nintedanib and the placebo, the absolute change from the baseline in total score on the K-BILD questionnaire at the 52 week, overall population 0.5, here is 0.79. The patient with the UIP-like fibrotic pattern, here is the 0.75, here is the 0.78. Acute exacerbation of the interstitial disease or the death at the 52 week, number with event upon total number, overall population, the 26 by 332, it's near about the 7.8%. Here is the 32 by 331, it is near about the 9.7%. Patient with the UIP-like fibrotic pattern, it is 17 by 206, near about the 8.3. And here the 25 by 206, 12.1. The death at the 52 weeks is the overall population, it is the 4.8% in the nintedanib. Adverse event, again the any and the most frequent, the diarrhea, nausea, bronchitis, serious adverse event, fatal adverse outcome, the adverse event leading to the treatment discontinuation, adverse event leading to the permanent dose reduction, which is seen near about the 66.9%, the diarrhea 28.9% is the nausea, 12% of the bronchitis, 32% having the serious adverse event, fatal was the 3.3%, but in the placebo case, this is the 5.1%, and the adverse event leading to treatment discontinuation is the 19.6%, nearby seen in the 65 patients. So if you conclude, patient who received the nintedanib has a slower rate of the progression of ILD than those who receive placebo, independent of the fibrotic pattern, based on this trial that the inbuilt 2020 US FDA approved nintedanib for the treatment of the chronic fibrosing ILD with progressive phenotype. FDA improved first treatment of or the groups of the progressive interstitial lung disease. So guidelines, then the official ETS and the ERS, JRS, uh, ALAT clinical practice guideline 2015, treatment of the IPF update on the 2011 clinical practice guide. Recommendation of suggest that the clinician use nintedanib in the patient with the idiopathic pulmonary fibrosis. Conditional recommended moderate confidence in the estimate of the effect. If you ask any questions or any query, but if you before that, you can go with the suggestive definition of the progressive fibrosing ILD in clinical picture. There is the relative decline of the 10% of more in the forced vital capacity, and the relative decline is the FVC was 5% or more with the decline in the diffusion capacity of the lung for the carbon monoxide for 15% more over the 24 month despite of the treatment. Relative decline in the FVC of 5% or more with the increased fibrosis on HRCT over 24 months of the despite treatment. The relative decline in the FVC of 5% or more with the progressive treatment and over the 24 months of the despite of the treatment. The progressing symptom with increasing fibrosis of HRCT over the 24 months of the despite of the treatment. The prevalence of the progressive ILD, the overall prevalence of the ILD was 10,000% was reported 0.63, to 6 in the 4 study in the Europe and 7.4 in the USA. The prevalence estimate for the individual progressing fibrosing ILD and the PF-ILD overall at presented in the table. PF-ILD prevalence per 10,000 patient ranges from 0.22 to 2% in the Europe and was 2.8% in USA. The result from the progressing study France, almost half of them, 48.1% were female and mean age was the 68.4. And the between the 2010 and the 2017, the estimated incidence of the PF-ILD ranges from the 4 to 4.7 per 1 lakh person year and estimated the prevalence of the 6.6 to 19.4% in the per 1 lakh of the population. The main diagnostic category represented were exposure-related ILD other than the HP. These are the results from the progressive study France. Median overall survival using the Kaplan-Meier estimation was 3.7 years from the start of the progression. And the during of the study, 95.2% of the patient has more than one hospitalization for respiratory care, and 34.3% were hospitalized in the ICU. The median interquartile range total specific cost per patient during the follow-up period was the 25,613 euro, and the median annual cost per patient was the 18,362 euro, for which 11,784 was related to the hospitalization. So the key features of the progressing fibrotic ILDs are the known are the common pathogenic mechanisms: self-sustained fibrosis, decline in the lung function, worsening dyspnea, deterioration in the quality of life, early mortality. Unknown are the marker predictor of the disease progression, selection of the patient for treatment, role of the immunosuppression, and the role of the antifibrotic therapy. Assessment of the treatment response, validated patient reported outcome. So the term ILD, it encompasses with the larger group of the more than 200 of the parenchymal pulmonary disorder, of which the majority are classified as rare. Early and accurate diagnosis can be challenging and it is difficult to predict disease progression. Most patients with ILD are cared for the pulmonologist, but the specialist from the other discipline may also be involved, like the rheumatologist. The idiopathic pulmonary fibrosis and several other ILD such as the HP, RA-ILD and unclassified disease may present a progressive fibrosing phenotype. If you go for the NSIP, patient with progressive fibrosing INSIP is have the restrictive ventilatory defect on the lung function test and lower DLCO. The clinical presentation of idiopathic NSIP is non-specific with dyspnea, cough, and the constitutional symptoms frequently reported. The progression is highly heterogeneous. Some cases are remain stable on or improve, but other can progress to the end stage fibrosis. A disease behavior classification is therefore useful to manage patient with the idiopathic NSIP. If we go with the unclassified IIP, the some patient are the unclassified and I, IIP has one of the more defined pathological entities like UIP and or NSIP. The characteristic ILD that may present a progressing fibrosing phenotype, unclassified pill IIP often have a progressive fibrotic component and present similarly to define the ILD that may present as the progressive phenotype type. The clinical features are include the dyspnea, dry cough, auscultatory crackle with no evidence of exposure or feature to autoimmune disease. The HRCT finding vary markedly and the mixed pattern of the lung injury common. The prognosis of unclassified IIP may be slightly better than that of the IPF, but the mortality rate is still high. It estimated in one study was 31% at 5 years. A low DLCO, the presence of the UIP fibrotic pattern and extent of the fibrosis on HRCT predict the mortality in the unclassified ILD. Patient with the unclassified IIP and HRCT features suggestive of fibrosis, high fibrotic score, the presence of the honeycombing and the presence of the UIP or a possible UIP. If we go with the sarcoidosis, approximately the 20% of the patient with pulmonary sarcoidosis develop the pulmonary fibrosis, stage 4 sarcoidosis, which is associated with the significant morbidity and mortality. The pulmonary fibrosis predominantly affect the upper lobe, the posterior segment, and the airway center with the no air trapping. The fibrosing tend to be the follow the bronchovascular bundle. The extent and the type of the fibrosis is highly variable. Imaging tends to reveal faint reticulation to dense linear band, cystic lung disease, traction bronchiectasis, and airway disorder. If we go with the HP, it is also known as the extrinsic alveolar alveolitis, is a complex, diffuse ILD caused by the repeated exposure and the sensitization to an inhaled antigen, most commonly avian, microbial, some especially the molds or the chemical. It present like a nodules or the faint nodule on the HRCT, which is the most, sometimes it is the perivascular. The HP is the third most prevalent ILD diagnosis after IPF and CTT. In some studies, the chronic HP is the more common. It is believed that the antigen inhalation result in a type 3 and 4 hypersensitivity reaction, which cause the alveolar epithelial injury. Abnormal repair mechanism may then lead to the fibroblast expansion, the activation, excessive collagen deposition through accumulation of the extracellular matrix and the destructions. So the diagnostic criteria of the category of the UIP based on the CT pattern, they are broadly classified into the 4 types. The typical UIP CT, these all are the CT pattern, and the probable UIP CT pattern with indeterminate of the UIP. CT features are the most consistent with the non-IPF diagnosis. If we classify into the 2 ways, the distribution and the feature, the typical UIP CT pattern is the basal predominant, occasionally diffuse, and the subpleural predominant. Distribution is often heterogeneous. Features are the honeycombing, reticular pattern with peripheral traction, bronchiectasis or bronchiolectasis, absence of the feature to suggest an alternative diagnosis. In the probable UIP pattern, the distribution is basal and subpleural predominant, and this is often the heterogeneous. The reticular pattern with the peripheral tractional bronchiectasis or bronchiolectasis, the honeycombing is absent, absence of the feature to suggest an alternative diagnosis. CT pattern with the indeterminate for the UIP, in the distribution is variable or diffuse, and the features are evidence of fibrosis with some inconspicuous feature of suggestive of the non-UIP pattern. In the CT feature, most consistent with the non-IPF, that is, it means when you not think that is the IPF, the distribution is the upper lung, mid lung predominantly, peribronchovascular predominant, and subpleural sparing. Any of the following predominant like consolidation, extensive pure ground glass opacity without acute exacerbation, extensive mosaic attenuation with extensive sharply defined lobular air trapping on expiration with the diffuse nodules or cysts. In these type of pattern, you should not think about the non-IPF diagnosis. So the key point of the chronic fibrosing ILD is the progressing fibrosing ILD is the phenotype in which the patient continues to progress despite of the conventional treatment directed to the underlying diagnosis. The definition of the progressing fibrosis should be integrate combination of the deterioration lung function, CT appearance, and the patient symptom. It is important to make an accurate diagnosis to ensure that the patient are treated optimally before progressive fibrosis can be ascertained. The multidisciplinary team should have the central role in the establishing and underlying the diagnosis and the assessing the longitudinal disease behavior on the conventional therapy. The antifibrotic therapy for the non-idiopathic pulmonary fibrosis interstitial lung disease should be considered as a second-line treatment for demonstration of progressing fibrosis despite of the conventional treatment. In the absence of the clinical trial data, the decision to initiate combination treatment with antifibrotic therapy and immunosuppression should be made on the case-by-case basis by the multidisciplinary action, taking an account a number of the patient and disease factor. So finally, you should know that the important point of the diagnosis and the management, it includes the multidisciplinary action of the fibrosing and the diagnosis and the treatment with the fibrosing ILD. If you can see the progression in the NSIP, this is the beautiful chart. I will give the 1 to 2 minutes to all of you to please see to how the CT changes. There are the 3 images A, B, and C of the axial scan of the high resolution HRCT. You can see that the patient with the fibrosing idiopathic NSIP having the restrictive ventilatory defect on the lung function test and the low DLCO. The clinical presentation of the idiopathic NSIP is non-specific with dyspnea, cough, and the constitutional symptom frequently reported. Progression is the highly heterogeneous. Some cases can remain stable, and you can see the HRCT pattern. But other can progress to the end stage fibrosis. A disease behavior classification is therefore useful to manage the patient with idiopathic NSIP. So you can see on all the 3 images of ABC, how does the disease progress, and few of the ground glass now converted into the pure reticulation with honeycombing and ground glass both. But in the idiopathic pulmonary fibrosis, if you go for the CT scan, the honeycombing and the traction bronchiectasis is more seen as compared to the ground glass opacities. Just spare the few seconds on that. The disease behavior classification is therefore useful to manage the patient with NSIP, and therefore useful to manage the patient with the idiopathic INSIP. So if you go for the fibrosis in HP, the natural history of the fibrosing HP and the UIP pattern is similar to IPF. whereby the progression occur despite treatment and the agent consider the appropriate may stabilize in the longer term in the response to the therapy. The chronic fibrosing ILD, if you can see that the uh, in the period of months to year, the usual consequential to continues the low level of exposure to a casual antigen, although in a significant number of the cases, the etiological agent cannot be found because mostly the it is of the having the no etiology, so it is called the idiopathic pulmonary fibrosis. Patient with chronic HP have significant worse health related quality of life than those with the IPF. The median survival from diagnosis of the chronic HP is 5 years. HP with either a UIP like or a NSIP pattern may be associated with the similar surgical rates to the IPF. Potential fatal acute exacerbation of HP have been reported in few articles. So if you go for the progression in the CT-ILD, the CTD-ILD associated with the fibrosing ILD include the RA, systemic sclerosis, idiopathic inflammatory myopathy, polymyositis, and dermatomyositis, the Sjogren syndrome, the systemic lupus erythematosus, and mixed connective tissue disorder. Of these conditions, the systemic sclerosis and RA are the most commonly associated with the ILD. RA-ILD typically progress faster in the patient with UIP than any other subtype, although the mortality rates are variable. In the systemic sclerosis ILD, most patients have fibrotic NSIP pattern on HRCT with a high proportional of the ground glass opacity with the peripheral distribution with subpleural and the basilar prominence and the low proportional of the course of the reticulation. This is the approach that the diagnosis and the management of the progressing fibrosing ILD interstitial lung disease other than the IPF. You can go this. I know this is a little bit busy slide, but you can go with the flow chart with the one by one box. So the fibrosing interstitial lung disease other than the idiopathic pulmonary fibrosis, the diagnostic test according to the international guideline, confidence diagnosis of the given interstitial lung disease, provisional diagnosis of the given interstitial lung disease or the unclassified interstitial lung disease, then monitor closely without treatment, or if that the patient condition is not good on or the HRCT finding are very aggressive, then go for the treatment, disease stabilization, follow-up of approach. If the disease progression is going, the progressing fibrosing ILD was made in the diagnosis, considering the adding the antifibrotic therapy. Or here, the stable disease, the follow-up and the appropriate case. This flowchart was published in the Lancet Respiratory Medicine 2020. So these are the suggestive studies type of the address the key of the uncertainty in the understanding and managing the progressing fibrosing interstitial lung disease. If ask the what is the prevalence of the progressing fibrosing ILD, the epidemiological studies and cohort study of the patient with specific interstitial lung disease, what is the optimal mean of the stabilizing the progressing fibrosis, and what is the earliest stage of which it can be identified, the integration of the data on the serum biomarker, imaging physiology and pathology with the deep learning algorithm, retrospective analysis of the longitudinal cohort study. If there is a robust set of the host and the disease parameter that can be predict disease progression, prospective study of the carefully phenotyped patient with the specific subtype of the ILD. If there is a subset of the patient or disease in which the immunosuppression is harmful, randomized control trial is carefully phenotyping the patient. If is it possible to predict which patient will develop the progressing fibrosing phenotype at the diagnosis? Retrospective analysis of the longitudinal cohort study, use of the artificial intelligence, including the deep learning algorithm. What is the most accurate means of the assessing the pulmonary inflammation that is the suggestive of the reversible disease? Randomized controlled trial of the immunosuppressive therapy is carefully phenotype patient with the consideration of the artificial intelligence approach in which the patient is a combination of the immunomodulatory and the antifibrotic likely to be efficacious. Randomized control trial is carefully phenotype with the patient. And what is the role of the biomarker in the predictive progressing fibrosis? Longitudinal cohort study is carefully phenotype patient with the specific subtype of the ILD. These are all are the suggestive study type to address key uncertainty in the understanding and managing the progressive fibrosing interstitial lung disease. You can see these are the charts of axial scan, spare 1 and 2 minutes on this the slide, or sorry, 15 to 20 seconds. You can see there is the reticulation with the diffuse involvement and a more in the basal part with few of the traction bronchiectasis with somewhere the air trapping is also. This is the chronic fibrosing where the injuries occur, epithelial cell activated, endothelial cell, and around the capillary, there is a deposition of the epithelial cell. Just a minute, the battery is getting low. Yeah. So the systemic sclerosis associated interstitial lung disease, the chronic connective tissue disorder characterized by the progressive fibrosis, endothelial dysfunction resulting in the small vessel vasculopathy, fibroblast dysfunction, and the resultant is the excessive collagen production and fibrosis and immunological abnormality. A study from the North India reported prevalence at the 120 cases per million. Lung involvement account for the significant morbidity and is a leading cause of the mortality in the patient of the systemic sclerosis. You can give the diffuse or the limited, sometimes the CREST syndrome or the esophageal involvement is also seen on the HRCT. This is the NSIP pattern. Again, just showing the axial scan of the, it is the HRCT images of the 46-year-old male who underwent for the lung transplant. The initial scan taken in the first admission, showing the ground glass attenuation and consolidation without the reticulation and the traction bronchiectasis along with the bronchovascular bundle, sparing the subpleural lung. A follow-up scan at the 3 year later showing the increased ground glass opacity and consolidation despite of the corticosteroid and the immunosuppressive therapy. This is the working diagnosis chart of the ILD. So this is all about on the ILD. If you have any question related to this with the progressing ILDs or these type of the other ILD and the non-specific ILD, you can chat on the chat box or you can ask directly by the raising the hand. I think this is the host and the speakers slide on the Zoom. You have your separate uh, uh, attendee slide. You can raise your question if you have any. Or you can mail me also your question. Dr. Chahat, is that okay?
Yes, sir. It's okay. Okay.
Okay, we will wait for 1 to 2 minutes. Then we will close this session. We will wait for 5 to 10 minutes. If there's any question, you can ask directly. This is the one of the slide which you can see on your screen of the comparison of the pirfenidone and the nintedanib. And you can clearly see the which drug is best. Pirfenidone, you have to start with the 200 mg TDS dose, and then later on you increase. The maximally you can give up to the 2400 milligram. The nintedanib, the capsule should be started with the 100 mg BD or the twice daily, and after that, when the patient is the tolerating the dose, you can go for the 150 mg BD after 15 to 20 days with the monitoring on the side effects and of that the liver enzyme definitely. But if the patient is having any liver disease, especially the scoring the type B and the C, you should avoid. And the in pirfenidone, you have to escalate the dose slowly as per the patient compliance, and watch for the phototoxicity also. These are the clearest management of the principle of the ILD. These are the but in the IPF, if you ask me, then you should only use the antifibrotic with of the reflux management and the oxygen therapy. And if the patient is having the pH involvement or the pulmonary artery hypertension or any sign of the core pulmonary, manage them. The long-term oxygen therapy is definitely very important. And the most important is the smoking cessation and the pulmonary rehabilitation. Okay, Dr. Chahat, I think we should close this.
Okay, sir. Thank you, sir.
Thank you, everyone.